So today we're covering respiratory infections, which is quite a broad topic. We've kind of covered this from a clinical approach. So we've sort of covered like causes of coughing, causes of nasal discharge kind of thing. But I do think it's probably the best way to talk about the differentials and then go down a little rabbit warrens for individual infections.
Mm.
So is there any clinical signs or infections that anyone's particularly interested in talking about?
Respiratory. Oh, everything in general, nothing in particular.
Mm-hmm. So it's
Maybe
not.
lungworm. Lungworm always scares me because when we were learning about feline asthma in vet school, they showed us a photo of a cat that was treated with steroids without checking for lungworm first and just developed like a fulminant
Or yeah.
kind of, yeah, pneumonia type.
I don't know whether steroids would contribute to lungworm. Like, I don't think that they would make the like lungworms more um like present. What they
Yeah,
would do is
okay.
make them more susceptible to a bacterial infection. Because anytime you've got a nidus, like a worm,
Mm, right, then
then
you
you
get,
get
yeah,
yeah.
okay, that makes sense.
Yeah, because worms have their own like immunosuppressant effects locally.
Right.
They stop like an inflammatory response to themselves in most
Yeah,
cases.
okay.
Yeah.
Okay.
So that yeah, interesting. Okay, cool.
So which lungworm was it and which country?
Oh,
Um,
Australian, I think.
yeah, Allurostrongylis abstrusis, I think it is.
Okay.
Yeah.
That's the
That
rat
it was just a
lungworm.
one photo, yeah, that they showed us in a lecture. But they didn't really go into detail about like what it was and whether they did BALs or figured out what was causing it. It was just it was an
Yeah.
X-ray of like the worst lungs you've ever seen after
Yeah.
starting the cat on steroids. But maybe it was just to remind us to check for other things before putting coughing cats on steroids.
Yeah, and it is a really good point because the differentials you've got in most cases, is it an infection or is it immune mediated or like
Yeah.
inflammatory? So like often we're in this situation where we're like, am I missing an infection? I really feel like I need to manage the inflammatory component, even if it is in response to the infection, but I need to know what infection it is if it's there.
Yes.
It's just there's no way to test for every single infection, particularly when the clients tie your hands behind your back and say, I don't have any money.
Yes, exactly.
I've
So,
heard that somewhere before.
yeah. Yeah, exactly. Um, yeah, because and this is something I found really hard studying for fellowships in infectious diseases, there's so many little things.
Mm.
Like, and the big sort of picture is the clinical presentation and the workup and what testing you would prioritize doing depending on where you live and the age and all the little nuances of the signalment and history. Um, and in a exam setting, you're sort of saying, well, these are all the tests I'm going to do, and I'm going to get the answer to what infection it is. But the reality is so different from that. Even when owners aren't cost constrained, tests do come with morbidity and stuff like a BAL. If the only differential in your list that you're doing a BAL for is lungworm, I
Mm.
wouldn't do it. I'd probably do a fecal float rather.
Yeah, yeah.
Yeah, if that makes sense.
Yes. Yeah, and if you're pretty convinced it's asthma, then
Yeah, yeah. There's
Uh,
patient morbidity associated
The
with any
float, the
condition.
float has to be a special technique for that too, doesn't it? A Beerman technique.
Spider-Man, yeah.
What?
Live.
Yes. What does that mean?
Look, I've forgotten that.
I think they're live larvae, so they won't float.
Mm-hmm.
Too.
Yeah. It's
Sort of,
actually spun. It's a centrifuge technique.
yeah, okay, yeah. Yeah,
Um, yes, so you're exactly right. They do their larvae with a distinctive S-shaped tail, apparently.
yeah. Yeah, yeah, I remember
Um,
that being very pretty.
very pretty. How common is lungworm in Australia?
I've never
Not
seen.
very, but it certainly occurs. It's been reported a fair bit from Brisbane.
Oh yeah.
It has been reported from Sydney. I think I've seen a couple of cases in Newcastle.
Hmm.
Um, Usually leaving food bowls out overnight and slugs and snails crawling across them.
Yeah.
Um, but eating prawns is another. Oh, I saw another case.
Prawns.
That's sort of shellfish are a intermediate host. Well, no, they're not shellfish, but of course I'm a bit vague on this, unfortunately, and it's much more common in the South Pacific, like the North South Pacific Islands and so on for that reason. And yeah, I saw a case in quarantine actually that picked it up somewhere in before it got here.
Yeah, right. So pretty much all of the lungworm we see here is Oslerus osleri. There is like another one, fox lungworm, which I've never been aware of, and realistically, you treat them the same way anyway. Why, in the populations that we would see in like a referral setting, why is lungworm much less likely than other differentials?
They're on preventatives.
Exactly, yeah. So how do you treat lungworm?
Is it fenbendazole?
Yeah, that's one of the options. What else works?
Well, if it's in the spine, it's steroids.
Oh, I'm actually talking about rat lungworm causes neurological angiostrongylosis. But because it doesn't cause a respiratory infection in dogs and cats, when I say lungworm, I'm talking about Oslerus osleri.
Okay,
Yeah.
right.
Yeah, so not the rat lungworm, just lungworm.
That's the one I was just talking about, actually.
Oh, okay, right.
Yeah, because that's the one Maya mentioned when.
Oh,
Oh, I was saying Allurostrongylos abstrusis, whereas
I
I
think
think
that's rat lungworm,
lungworm is
isn't it?
Angiostrongylos.
Cantonensis.
No, cantonensis.
Yes, that's the one.
Yeah. We get confused when we get older.
Where's Ellorostrongylos live?
I thought we had
Oh,
Allurostrongylos.
it is. It's feline. Yeah.
Yeah.
So Oslerus osleri in dogs and Ellorostrongylos abstrusis in cats.
I think that's much more common in the UK, isn't it?
I don't actually know, but what I
In
was
Europe?
getting at is that the preventative medicine that most of the patients we see in a referral setting are on treats lungworm. So never gets a chance to set up. So if you've asked about what preventative medicine the patient's on, and if it's on an antiparasiticide for like combined therapy for heartworm or not heartworm, but
Ticks.
fleas and stuff, yeah, most dogs are covered. Most dogs and cats are covered. I'm out of touch with what's available for cats actually. I don't know if because it's mostly Bravecto and that doesn't actually have an anti.
They have NextGuard Spectra now for cats.
Oh, is there? Yeah.
Yeah,
Okay.
the NextGuard Spectra's their big thing is that they cover for lungworm, whereas Bravecto does.
Oh, yeah, right. Okay, there you go.
I don't know if Advocate covers lungworm. That's a really common one in cats.
Yeah. So that's one of those things when I'm sort of doing my history, like how am I going to prioritize what testing I want to do here if I can't do everything? Is if they've been on preventative medicine, lungworm's really, really unlikely.
Yeah. I think I get a bit worried with the cats that are indoor only, and so the owner feels like they can't catch a parasite, so they don't have them on preventatives. And I'm worried about what if a snail crawled into the house or something, but
yeah,
that's
true.
So how is Allurostrongylos spread then? The same way as Angiostrongylos?
It's from a snail.
Yeah. Mollusk intermediate host. Yeah.
So they both spread the same way then.
Yeah.
Yeah, but I've never heard of prawns spreading it, but maybe.
I think that might have been the neurological one that Jeff was talking about.
Yeah, rat one. Yeah.
Yeah. Where we are the unintended hosts.
Yes, so then it doesn't know where to go, so it goes into response. Yeah.
Yes.
Yeah, there's a rather famous case of a young male who was dared to eat a slug, and he did that, and he got the rat lungworm
Yes.
from it. Was
Mm.
treated and survived for a while, but he did subsequently die.
Yeah, I did read that.
It's
That's
been
awful.
it was years though. He only died quite recently, I think. It was like 20 years or something. He was impacted by it, or his whole family was impacted by it.
Mm.
Good. So how would this patient, so say we did have a patient that had lungworm, let's say it's a cat. How would this patient present typically?
Well, cough probably.
Yeah. Well, cats hide their coughs. They're very good at getting severe lung disease without ever coughing.
Mm.
What else might we see?
I don't know. I'd only be guessing tachypnea.
Exactly. Yeah, just respiratory signs, right? Like they're not actually systemically unwell. They're not going to have a fever. So again, part of that kind of prioritizing your testing, if you've done a physical exam and the animal's not actually hot or showing evidence of sepsis in other ways, and we've just got increased respiratory rate and a little bit of dyspnea, then lungworm should be on the list. Bacterial pneumonia, less likely. How long would they have shown signs for?
A cat, not long, because it's not until late in the disease that they show clinical signs most of the time.
Very good. And cats hide their clinical signs for so long as well. Cats are interesting because they do get that reactive, like they essentially get reactive asthma. So they get bronchoconstriction in response to inflammation in the lower airways. So lungworm is going to cause asthma. So it's not incorrect to call this asthma, except that asthma doesn't have an infectious etiology. So I mean, or it's infectious asthma, or reactive asthma. So they can present quite acutely when they get bronchospasm rather than from the symptoms of the worms themselves. So say we've got a farm cat that lives outside and definite exposure, not on any preventative medication, and presents with asthma. Well, asthmatic signs like acute onset of tachypnea, dyspnea, and a bronchial pattern on radiographs. What testing are you going to prioritize doing?
I think an X-ray probably,
Yeah.
if you can, without stressing it too much.
Yeah.
So in a farm cat, I would also consider clotting tests if they've got rat out.
Very good. Yeah. Yeah.
Sorry, what was that, Katie?
I would recommend clotting tests.
Oh, clotting. Right. Okay.
A lot of our farms will have rat bait out, and so obviously they can bleed anywhere. So some of them will bleed into the chest.
Yep. It's a good idea. What else?
T-Fast.
Great. Excellent. So that's another nice one. So say they say, no, I don't want to pay for the clotting tests. No rat bait at my farm. You're very unlikely to get a bleed from rodenticide into the lung itself. You'll get it into the pleural space. But T-Fast will help you differentiate that. What else might you see on a T-Fast?
Like pericardial effusions.
Yep.
You may see like nodular signs on pleural space potentially.
Good. Yep. Excellent. So nodules. What else in the lungs might you see in an asthmatic cat?
Crazy amount of B weights.
Yeah. Yeah, exactly. B lines, we'll call them. Does everyone know what they are? Yeah, and what they look like? Jeff, have you seen B lines before?
I think I might have. They're a sort of an arrow type, like a line.
Yeah, just straight.
And it's fluid that transmits the ultrasound wave.
Yeah, exactly right. So if you've got inflammatory infiltrates, there's more cells in there relative to the amount of air that's normally there, and those cells will allow those sound waves to get deeper into the lung than they would if we had a nice, clean, air-filled lung without cellular infiltrates.
Yeah, just a question you said about pleural space hemorrhage with rodenticides. Is that cats only?
Both actually.
Both. Because the ones I've seen in dogs have been coughing blood.
So they absolutely can bleed into their lungs, but they present coughing up blood. So it's a very distinctive presentation. Whereas if you've got a patient that's just come in dyspneic without any hemoptysis, then I would say it's almost impossible that they've bled into the lungs. That blood has to go somewhere.
Right.
Without it comes out when they're
Because I saw a dog in Adelaide that I was about to write off as kennel cough, and the owner said, "Oh, he's coughed up a little bit of blood."
Oh, yeah.
So we potting tested him, and sure enough.
Rodenticide.
Mm.
It's I don't know if it's good or bad to bleed into the lungs. Better than the pleural space, I think. I'm a little bit haunted by a rodenticide case that was like just bleeding into the thorax, and I was pulling the blood out and putting it into the vein and pulling the blood out and putting it into the blah, blah, blah. And it just bled and bled and bled. I think we did it for about 2 hours until the transfusion was in and the clotting factors in the transfusion were in.
Wow. That survived.
It survived, yeah, it was fine actually, but I missed daycare pickup, which is why I'm traumatized by it. I really couldn't get to the phone.
Fresh frozen plasma will stop it.
Yeah, that was
very quickly
running in as we were like, so I was like, defrost it faster, and they're like, we can't.
And you can give vitamin K IV. I've got a formula for it somewhere that they used in Wagga successfully during the mouse plague.
Oh yeah.
They just released a study on it as well.
Oh, cool.
Yeah, we used it in Gundy a lot because we had a rat plague, and it's meant to clot in 3 hours compared to subcut, which is like up to 12 to 24.
Oh, interesting.
Yeah, they've just someone released a study because I sent it back to my work, and I was like, we were ahead of the game.
Yeah. Complications?
In humans, they can have really severe perivascular, like thrombosis, or like mainly from the injection site.
Yeah.
And you can get anaphylaxis, but in the study that they released, that was very, very minimal. If any. So they were like, it's actually very safe in dogs from the study. Yeah, very cool.
Yeah. Oh, that's a hot tip. So what we've done a chest X-ray, we've done a T-fast, we've done ABTT, PTT, APTT, PT.
Yeah, that one.
That one, yeah. We've done coags, let's say that. What else are we gonna do?
Full blood count might be a little bit helpful.
Yeah.
You might expect to see an eosinophilia if it's that long one.
Yeah. And what if it's a bacterial pneumonia?
You'd expect a neutrophilia.
Good.
Excellent. Who's going to get anything?
Yeah. I just cats are really good at hiding their neutrophils too. They're just good at hiding everything. They just when a cat's got a neutrophilia, I'm like, oh, it's really bad. So yeah, I'd expect that cat with a neutrophilia to be really sick. Whereas, like, what organisms might we see causing a pneumonia, which might not like cause that much, might be quite severe pneumonia, but actually that animal's not that unwell. Don't know. What are the most common causes of bacterial pneumonia in a cat? I'm gonna look this up.
Pasture elements? No, I'm guessing. I don't know.
Well, it's a good point you raise because it's mostly oropharyngeal organisms that get down into the lungs. So most of the time, what causes pneumonia is just what they've inhaled, basically, that's gotten lodged down there, and they might have asthma or they might have bronchitis or something that's predisposed them to not being able to clear that through the normal mechanisms. But if we're talking about respiratory pathogens, like respiratory infections, what are the like obligate pathogens that we see as part of the It's not as much in cats, but
Is it mycoplasma?
yeah, so that's a big one. Yeah.
Bordetella causes it as well, theoretically, in cats.
Yeah, it can. Yeah.
Mm.
Sorry, just looking at this. Strep is another one. To the strep canis in dogs, strep equizooepidemicus. And gastrointestinal, the coliforms, will cause opportunistic infections. They're just really inflammatory, like the what's the word when an organism is very virulent? Is that the right word? Like it, if you get a gram negative anywhere apart from in your gastrointestinal tract, it's going to cause a fever, it's going to cause a really profound inflammatory reaction, cytokine storm, all of that stuff. So E. coli and Klebsiella and things can also cause pneumonias that can be hard to clear.
Mm.
And they usually present pretty sick because they've got gram negatives down there.
Mm.
Let's talk about dogs as well while we're talking about bacterial pneumonias. You mentioned Bordetella. What's a classic presentation for a dog with Bordetella?
Just
Goose honking cough.
Yeah, exactly. Yeah. So it's actually a tracheitis, isn't it?
Mm.
How often does that progress to pneumonia?
Rarely, I'd say.
Very rare.
Very rarely.
Yeah. And most dogs are vaccinated now, which means that the infection's less severe. So much, again, even less likely to progress to pneumonia. If a dog presented with an acute onset honking or harsh cough, and it's a social dog, gets out and about, has been in boarding or whatever, so high risk of infectious disease, what's on your list of causes of canine infectious respiratory disease complex?
Well, dynamic airway disease will also cause that sort of cough, I think.
Yeah, let's say it's a 2-year-old.
Let's say
All right.
2-year-old.
a year old.
Yeah, just a pup. So it makes the degenerative processes much less likely.
Well, distemper might, but we don't see that anymore.
No, and I don't know if it actually causes cough. Definitely upper respiratory discharge, like nasal discharge. But I'm not sure that cough is a big.
Yeah, that's a good point.
Oh yeah, you're right. It is. Yeah.
I don't know that I have seen them coughing. It's more, the outbreaks I've seen, they'd get them out of the car and they'd seizure in the gutter.
Really? Mostly neurological.
Yeah.
Okay.
But the nasal discharge and cachexia, loss of body weight.
Yeah.
But my theory is that was the old wives' tale about a dry nose.
Oh yeah.
Because dogs with distemper had dried mucus on their nose, so they had a dry nose.
Oh yeah, right.
That's the Gibbons theory.
Yeah. Love it. So
It's unpublished.
what other viruses should we think of?
Parainfluenza,
Yeah, great.
adenovirus.
Great. Excellent. So vaccinate for both of those typically.
Yeah.
There's a bunch.
Herpes virus can theoretically cause it.
Yeah, exactly. Yeah. The respiratory coronavirus. So human coronavirus in theory. Causes very mild signs if it does cause signs at all. There's a recently identified one called pneumovirus as well, which isn't a big problem basically, so it's not something we need to worry about. But one that we should probably have on our radar is influenza, actually. Has anybody heard about any outbreaks of influenza? There's been a few big kind of outbreaks in the US. that have been investigated, and they have caused quite significant, like very infectious. So it just spreads through dogs really quickly and at quite a high morbidity and mortality. But I think the mortality is increased by owners that are unable to support them through like ventilate and stuff like that. So emerging importance for that one, just watch this space. I'm not sure whether we've actually got that in Australia. I haven't heard of any in Australia.
Is it zoonotic?
No, it's not actually specific, species specific.
Mm.
I'm just asking ChatGPT. It's thinking.
Gemini is not currently endemic, but has been identified in imported dogs.
Oh, okay, right. Okay. It's not present in Australia. I've got exotic, nationally notifiable under AusVet plan.
Oh.
Yeah, so but it's been USA, South Korea, China, Thailand, other Asian countries. So it's not far off.
In Australia, how like would you go about testing for that?
That's such a good question. I would
Obviously it wouldn't be in any of our PCR panels or anything.
No, that's true. I would definitely recommend consulting AusVet plan.
How do I notify them when I don't know what it is? Like,
Yeah, yeah, that's a really good point.
That might be that.
Yeah. I wonder if there is any surveillance going on for it. I guess like dogs have individual like value to individuals rather than like economic importance as far as like there's no motivation for the government to be doing surveillance for that.
Yeah.
So I'm just going to look up what is actually on the respiratory PCR panel so we can talk about it.
It makes me feel so much better that you sometimes have to Google this stuff too.
Oh yeah, oh my God, I love it. And I really think
I have to look at my IDEX PCR panels to actually see what I'm testing for before.
yeah, exactly. And so much of it is just not important at all. Okay, so canine respiratory, no influenza. So Bordetella, adenovirus, herpes virus, coronavirus, parainfluenza, crypto, which we'll talk about, Aspergillus, interesting, Mycoplasma cyanos, which is that it's actually one of the pathogenic mycoplasma organisms that will cause like walking pneumonia, so they can be quite well and getting around, but their x-rays are like spectacular. Mycoplasma canis and pneumocystis, which is exciting. So what say you've got this coughing dog and it coughs for a week and then it becomes a little bit pyrexic and it starts to look a little bit unwell and you do some blood tests and it's got a neutrophilia. You want to do a PCR panel, but what are you going to test? What are you going to do the test on?
I would think that a BAL would probably be the best.
Yeah. What about the dog that presented on day one with just a cough and no pyrexia, no neutrophilia?
Probably wouldn't send a PCR.
No, probably not. But we're in a test situation and we're doing all the tests. Exam situation.
Pharyngeal, like deep pharyngeal?
Yeah, I reckon probably a pharyngeal swab. And the reason why the difference in like the sample that you're going to send off is because if you've got a pyrexia and systemic illness, very unlikely to be an infection that's isolated to the upper respiratory tract. It's going to be lower down. Whereas if you've got all the signs localizing to the upper respiratory tract and no systemic signs, that organism is much more likely to be on the surface of the upper respiratory tract, and that's where you're going to take your sample from. So of those differentials that the PCR panel is testing for in our neutrophilic pyrexic dog, which ones are of concern? Like which ones are you thinking are most likely?
I would think probably Bordetella is.
Yeah.
Yeah.
Yeah, with that history.
Mycoplasma potentially.
Yep. Yep. But almost certainly bacterial if we're a week down viral would have kind of gotten better by now, typically, unless we had a viral and now we've got a secondary pneumonia. So there's nice ISCAID, the antimicrobial stewardship recommendations for when to use antibiotics as a kind of empirical measure. And that's basically that dog that I just talked about. When they've been coughing for like more than a few days, they're pyrexic or neutrophilic, that's when you want to use some antibiotics. 16 out of 17 of the panelists on the ISCAID recommendations recommended using doxycycline as the first choice. They also said that clav was a good second option. But there was less agreement on that, but doxycycline was the one that most people said that's what you should start with. Why would those specialists say that their preference was doxycycline over clav?
Reaches the lungs better.
Good. Yes. Excellent. Yep. And
it's also mycoplasma is susceptible to it.
excellent. Yeah.
My understanding, though, with kennel cough is that the organisms glue on the cilia, so they're a bit hard to get at with systemic antibiotics.
Exactly right, which is why you kind of almost just need to support them through it and not give them antibiotics. So the reason Maya just said the doxycycline gets into the bronchi. So bronchi are one of the places that we get the least penetration. So if you give 20 milligrams per kilo of clav and that reaches a peak serum concentration of blah, less than 30% of that blah is actually going to get into the bronchi. So the concentration of antibiotics at the site that the bacteria is very low. So doxycycline is quite good in that I think it's like higher than 30%, but clav's around 30% penetration into the bronchi, and that's one of the better antibiotics. So it's important to have a look at the antibiotic that you're thinking about prescribing and say, is it actually getting into the lung when you've got respiratory or upper airway when you've got respiratory infections? And inner ear as well. I'm going to include that in upper airway. Its penetration is quite poor, typically. And it might be the best choice for the organism, but the wrong choice for everything else. The other antibiotic that was discussed and is anecdotally reported to be very effective, particularly for Bordetella, is gentamicin through a nebulizer. The downsides of that are our exposure to it or the owner's exposure to it. So it's not very responsible from an antimicrobial stewardship perspective to have people exposed to a gram-negative directed antibiotic aerosolized at low concentrations, because it's that's one of the kind of factors that contributes to resistance development. And then the other thing that's discussed, but we don't have really good consensus on, is that it might actually be inflammatory in the airways. So it gets rid of the organism but causes inflammation. So it might actually exacerbate the cough a little bit. But it is an option if you've got a patient that can't tolerate oral antibiotics or is refractory to them, is not responding to them, potentially. Just with caution.
Where would you get that? Would you just put
It's
like injectable?
Yeah. You just put injectable in the nebulizer instead of saline, or with saline, in fact. We used to do it a fair bit for our aspiration pneumonia dogs in the clinic that I did my training in. And then subsequently, I've worked in clinics where they're like, absolutely not, I would never do that. It's too dangerous. It's just people's opinions, really. Okay, so I'm going to change the signalment of this dog that we're talking about to a Cavalier King Charles. It's not pyrexic, and it's a little bit neutrophilic actually, and it's a bit sick, but not fully sick. And it's been sick for 2 weeks, progressive increase in coughing.
How old is it?
It's 2.
Oh.
It's not heart disease.
It
does not have a heart murmur.
Oh, you're ahead of me as usual.
But that's a very good consideration. It would be very easy if this dog was 12 with a heart murmur to just go hit some furosemide. See you later. What testing are you going to do?
I think BOAS is probably a consideration there.
BOAS?
Cavalier King Charles,
Hmm.
they're a bit snub-nosed, aren't they?
They are, but how would that contribute to an acute onset cough of 2 weeks duration that's progressive?
Yeah, okay, yes. Through a degree of mild inhalation.
Yep. So often they've got laryngeal, not paralysis, what's the word?
Paresis.
Yeah.
Edema?
Collapse. That's the word I'm looking for.
Right.
So they've got decreased laryngeal function. They are more prone to aspiration, and often they've got this gastroesophageal reflux and microaspiration kind of process going on, which means that they're aspirating tiny bits of acid a lot, damaging their mucociliary mechanisms and their ability to clear infections. So they are more susceptible to aspiration pneumonia, those BOAS dogs. So that's a consideration for sure. What else?
Keel collapse, or is it a bit young?
I would never say never because some dogs have got congenital abnormalities of their airway, which can cause like tracheal collapse from a very young age, particularly Yorkies. It's a very specific, like genetic, what I'm searching for. It was one of the organisms in the respiratory panel that Cavaliers specifically are genetically predisposed to causing pneumonia.
Oh, never heard of this.
So it's so interesting. It's a fungal organism called Pneumocystis canis,
Oh,
and it causes quite a profound pneumonia. But because it's fungal, it doesn't present like a bacterial pneumonia. So they're not like really neutrophilic. They've got like really profound changes on their x-rays most of the time for the degree of illness that they have. And you can actually see the organisms on a BAL typically. So BAL's diagnostic for these guys. But they've put it on the PCR panel. So even if you don't have enough organisms to spot, you're more likely to detect it with a PCR. And it has no business being in the lungs. So if you do detect it, it's significant.
Similar to Aspergillus, could diagnose it on serum with PCR.
Sorry, it just got a really fuzzy sound. I don't know why.
Sorry, I was just asking if it was kind of like Aspergillus,
Mm.
where you detect it in serum
Mhm.
on a PCR if it is quite severe in the lungs.
I don't know whether it would show up on a serum sample. I think you'd be much more likely to get a false negative on a serum sample. I think much more likely on either respiratory swab, most sensitive on a BAL, because those organisms are right down in the lung. So they'd have to have coughed them up to show up on a respiratory swab. But yeah, interesting disease. Let's talk about Aspergillus now that we're talking about it. How would a dog present if it had an Aspergillus infection?
More nasal signs?
Definitely. So pneumonia, Aspergillus pneumonia is like they have to be immunosuppressed basically to get it. So much more commonly we see sinonasal aspergillosis. How does aspergillosis differ in cats and dogs in presentation?
Is it that dogs will be more chronic? Cats present a bit more acutely.
Yes, because cats don't like to cough and sneeze and show that they're unwell. But it's actually the distribution which is different. So dogs typically get sinonasal, by far the most common. It's very rare for dogs to get orbital involvement. of the aspergillus, whereas cats quite often present with exophthalmos with a retrobulbar aspergillus granuloma, essentially. So they kind of get almost like a mass lesion rather than like a really erosive osteolytic process, which dogs get.
Mm.
And cats can get the erosive osteolytic one as well, but it's actually Aspergillus fumigatus that causes that type. And then I think it's Aspergillus felis that causes the mass lesion. So it's actually different Aspergillus organism. Sino-orbital aspergillosis has a terrible prognosis. So we can get antifungals into the sinuses and nasal cavity, but we can't really get them into the orbit. So it's very hard to treat. And we're very reliant on systemic therapy, which again just doesn't penetrate those areas very well. So I've only ever managed one of those cases. I'm sure I've missed cases now because this is kind of fairly recent research showing that retrobulbar mass lesion is probably an Aspergillus granuloma. But it didn't go well at all, went into its brain.
God.
Yeah. Have you guys ever seen aspergillosis in a dog?
I've seen systemic twice.
Have you?
Both German Shepherds. One of the German Shepherds was so badly affected that I could lift it with like one hand. It was so skinny.
Oh, wow.
Yeah, and I can usually not lift a German Shepherd on my own. So yeah, it was crazy. And the other one was a German Shepherd that came in with bilateral retinal detachments and completely systemically well.
Yeah.
And so we did Aspergillus serology, among other things, and sent it off to medicine. And medicine did a full workup, and then the Aspergillus serology took like a month to come back. And by the time I came back, I called the owners back, and they said, "Oh, well, now the dog's not systemically well. We're actually thinking of euthanizing it." But yeah, it was positive for it, and it had spinal signs by that point. And yeah, we started it on antifungals, but I'm not sure what ended up happening because then it was managed by the medicine team.
Yeah.
But yeah, that's a crazy case.
I've seen quite a few up here, and we actually last year started using galactomenin as a monitoring for some of the systemic things we saw. We also used galactomenin on a BAL to diagnose a different type of fungus in this dog. There was just waxing and waning fever, coughing signs, nothing on PCR, nothing on CT. But we picked up, it had a high galactomenin in the middle range, which is like kind of, but it wouldn't PCR aspergillus. So we assumed it was probably a different fungal because they had some cross reactivity with the galactomenin. Anyway, it was really, really cool. Our galactomenin was okay at monitoring it, but I
don't think it's what, sorry?
We had a dog that was improving CT wise, and its galactomenin was going down, and then it had like, oh, is it because of that, or is it just? It's pretty cool to use.
Yeah, that's awesome. There's a internal medicine specialist called Jo Whitney, who's just done, you know her, yeah, she's done so much work on aspergillosis. She's just the person that, and I don't even think about aspergillosis. I just contact her. What do I do? Yeah, but it's particularly systemic is such a different syndrome, and they have to either be immunosuppressed or be a German Shepherd who have an immunocompromise, which makes them susceptible to aspergillosis. Have you seen your systemic ones, Katie? Have they been German Shepherds?
Yes, I think the 3 that we had last year that we were using with galactomenin. And funnily enough, 2 only presented with head tilts. And 1 presented with a mass. But the other dog with the lung fungal that we haven't been able to culture or whatever, but it responded really well to antifungals. It was a cattle dog.
Cattle dog.
We think it may have had on the CT, there was a swelling on its neck region,
Oh,
maybe a migrating foreign body,
yeah,
may
right.
be predisposed to something weird.
Something got in there.
Yeah, but it responded really well to the systemic. We were like, okay, well, it's probably fungal. We might just never culture it.
Yeah.
Working.
I saw a case in America. What the surgeons had done was actually lifted the nasal bones off and exposed the nasal mucosa and all its bones. And I had the job as a resident of irrigating that every day, and the dog used to hate it because it's so sensitive.
So sensitive.
Yeah, so
Um,
I don't remember whether they got a cure or not.
we have, like, when I started my training, we used to do like the trephination into the frontal sinuses and then leave indwelling catheters in there, and just infuse clotrimazole every day or several times a day, because obviously everything's designed to drain out of the sinuses, right? So what we need is contact time for effective resolution of the infection, and that's what we can't get. And there's been a lot of research into different ways of improving contact time, but it's the indwelling catheters is definitely theoretically the best, but ethically tricky.
Yeah, I used one. I think I saw a couple of cases in Wagga. I used the catheters in one. I'm not sure whether we did the other one, the 45 minutes anaesthetised with a nose full of antifungal. I don't know that we did that, but
there's a product called a poloxamer gel, which we've used a few times. So it's a gel that is liquid when it's cold. So in the fridge, it's runny, and when it's at body temperature, it's actually quite solid. And there's a study in like the American Journal of Veterinary Research that showed retention in the sinuses was much higher using clotrimazole in that rather than in the cream or commercial formulations that we use, or the soaks. So we've used that quite a few times. It still just comes out like it's now, rather than trephining, because most of these dogs are big, we can get the scope up into the sinus, flush it out endoscopically, and then deliver put a red rubber catheter in guided, and then deliver the poloxamer directly into the sinus rather than trephining. It only works in dogs with long noses or dogs that are big enough for the flexible scope to get in. But that's a lot less invasive, and which I don't know, that's totally anecdotal, but I feel like the rates of needing to repeat were similar to the trephining. So it's like 60% success and a lot less invasive to repeat. Okay, we've only got a few more minutes, so let's talk about a cat with. Okay, we've got a 1-year-old cat who presents with nasal discharge, sneezing, and stertor. It's a little bit quiet and off its food, but not systemically unwell as far as no pyrexia or anything. What differentials are you thinking about in this patient?
I've got a feeling nocardia could be on that list.
Could be. It would be a zebra. 1-year-old upper respiratory infection. What is more common?
Herpes.
Yeah, totally. Yeah.
Chlamydia.
Mm-hmm.
Mycoplasma.
Yeah, good.
I guess it could theoretically have something like a polyp, but I don't know if in a 1-year-old how likely that would be.
Yeah, they're actually more common in younger cats when I first started. Because I was like, I could be a young cat. And then I thought, especially, they're like, yeah, the textbooks will say it's a little bit older, but they're normally like 1-year-old.
I agree. I've only ever seen them in under 5s.
The polyps? Okay, I've never seen one, so.
Mm.
Yeah.
But yeah, when I googled it, it said that they were like a little bit older, and I was like, well, maybe not.
I wonder what ChatGPT says.
Yeah,
This
it's the
is
ultimate test now.
Yeah.
also like 5 years ago when I was like fresh new grad, and I like
Yeah.
looked down this cat's tongue, and there was like something dangling at the back of it, and I was like,
It's so rewarding. I love polyps. It's so like there's so few things medicine people get to fix. Gastric foreign bodies and polyps.
Foreign body
Uh,
herpes.
what you mentioned herpes and chlamydia. What's the other one that makes up the cat flu complex?
Mycoplasma?
Not cat flu
Okay,
complex.
flu.
Yeah. It is an organism that could absolutely cause those signs for sure. Oopsie.
is it corona?
No, so we've got herpes, chlamydia, and
Calicium
Lacey. Thank you.
can cause the. Is Calicium the one that causes the oral ulcers?
Yeah, for sure. Yeah. So nasopharyngeal signs are as common for all three of the viruses. Herpes tends to cause eye changes and nasal. Chlamydia, eyes and nasal and oral, I think. And Caleci tends to be oral and nasal.
Mm.
So you don't typically get ocular signs for Caleci, but it's still possible.
Mm. Yeah, and I had an ophthalmologist with a good mnemonic. He said herpes H for hyperemia in the eyes,
Yeah.
and then chlamydia C for chemosis, because the chlamydia tends to cause chemosis more, and the
Oh,
herpes tends to cause more
interesting.
hyperemia.
Yeah. Great. Okay, I'll remember that now.
Yeah, it's a good mnemonic.
I'm just looking at average age for nasopharyngeal polyps, 1 to 2 years.
Okay. Very young.
Yeah. Uncommon in geriatric cats, it says.
Mm.
And if you've got a mass lesion, much more likely to be neoplastic, obviously. Okay, so cat flu is typically those three things. This is a 1-year-old cat. It's kind of like we definitely do see cat flu symptoms, but they're never as severe in once cats are fully grown as in those tiny little kittens who can't breathe. Mycoplasma is also on the list. What else should we have on our list?
Crypto.
Crypto, good, excellent. Anything else?
Crypto's the one that causes the granulomas, is it?
It is, yeah.
Yeah,
Exactly.
I think that's what I was thinking of rather than nocardia.
Mm.
Just because I
Oh,
also
yeah.
got the impression in Adelaide we saw a lot more fungal infections than we would in Sydney.
Yeah.
Also had a couple of them there. There was a cat that was being investigated for a mass. Where was it? I think it was in. Oh, it was in the head somewhere. I just can't remember whether it was respiratory or what.
Mm.
And when they biopsied it, it turned out to be crypto.
Mm. So I've worked, we had a cat with a brain tumor, which we MRI'd and was called most likely meningioma. So we went in and removed it, and it was a cryptogranuloma.
Wow.
It had come from the nose and gotten through into the brain, and then the cribriform plate had kind of closed up again, like grown over, and this fungal granuloma just had to come out anyway, but maybe
Wow.
there was an easier way to get it.
I've worked
Great.
a weird dermoid cyst cause sneezing, sternum, and a nasal discharge. I've had a cyst coming up, had an exit wound at the top of its nasal plenum, and went all the way to its cribriform plexus. Yeah.
Wow.
As a student, we CT'd it. But yeah,
Wow.
it had a little bit of sneezing. It didn't really have the nasal discharge, but it just had this mass that was coming up and going down.
Yeah. Do you know what? Like, so often, because I go into general practices and people are like, oh, it's not going to be that. It's not going to be that. And I'm like, it often is something weird. It's just that we traditionally haven't done that advanced imaging and stuff. Like, you have to have it on the list and be aware that this could go pear-shaped. Like, we can treat for this thing that's 90% most likely to be, but there's a very good chance that this is going to go pear-shaped because it's something very strange. But but I've never seen that.
But I have a dog that came in and I was like, I think this is cutaneous lymphoma. And the owner was like, nah, let's just treat it. I said, I'll treat it as allergic skin disease. I did a biopsy. It's lymphoma.
Yeah, had to do that trial to get the biopsy across the line though. Jam. At least you kind of picked it, hey? Like you can warn the owners. It's when it's a surprise to everyone that it's harder to reach. All right, I'm gonna have to wrap up. Thank you so much. That was a really fun session. I have no idea what we're talking about next time, but I look forward to it.
Thanks so
Yeah,
much.
thanks, Anna. It was really good. Yes, it was.
Yeah.
And thanks everybody else.
Bye.
Thank you.
Bye.